Good morning and welcome to session 1A, Partnering to Improve Behavioral Health Outcomes for School-Aged Children. My name is Emily Beber. I'm a licensed professional counselor at the Children's Hospital of the King's Daughters, and I have the honor of hosting today's panel. Just as a reminder, everyone is muted. We will have a Q&A box at the bottom that you can click on to submit any questions that you may have during the session. We will have the last 10 minutes of our session today to answer those questions. In addition, feel free to chat with one another in the chat box that will be along the side of your screen, and we'll monitor that. Let's begin with some brief introductions. First, we have Shella Dennery, Dr. Shella Dennery, who is the director of the Boston Children's Hospital Neighborhood Partnership Program. Dr. Dennery has spent her career working as a school social worker in the Boston Public Schools and teaching and consulting on behavioral health related topics in community settings. She partners with the Children's Mental Health Campaign to advocate for increased access to care and systemic change in behavioral health care for youth across Massachusetts. Dr. Dennery is adjunct faculty in social work at Boston College, Simmons University, and Smith College, and is an instructor in psychiatry at Harvard Medical School. Welcome, Dr. Dennery. We also have Dr. Charmain Jackman, founder of Innocyc. Dr. Jackman is a Harvard-trained licensed psychologist with over 23 years of experience in the mental health field. She is the national spokesperson on Black, Indigenous, and people of color BIPOC mental health and advocates for emotional wellness for all. Dr. Jackman has worked in schools for over 17 years and served as the Dean of Health and Wellness at Boston Arts Academy for the past 10 years. Dr. Jackman is the founder and CEO of InnoPysch, a mental health tech startup on a mission to disrupt racial inequities in mental health. At this time, I'm going to turn it over to Drs. Dennery and Jackman. Welcome.
Thank you. It's great to be here. So it's an honor to be here, especially with Dr. Jackman, who I've worked with for many years and am always so happy to be a part of anything that she's a part of. The only thing I would add to my introduction, I mean, I've been in working in schools. I'm a social worker for 21 years, but I have a second and fourth grader, 2 boys at home, which I think also makes this personal and professional, a lot of the things we're talking about today. Charmain, did you want to add anything to your introduction?
Yes, thank you. And it's a pleasure to be here as well. I have had the opportunity to work with Shella in a hospital/school-based setting, right? That's a partnership. But I've worked in juvenile courts, I've worked in community health centers. I have my own private practice. And another piece that I think is important is I'm very civically involved. So I am on the board of Big Sister of Greater Boston, the Citizens for Juvenile Justice. And I'm also a parent of a middle schooler and a third grader. So we've gone through this whole pandemic situation together. And so like Shella, bringing both the personal and professional to this talk today. So excited to get into it.
Great. So just to give you all an overview of what you've signed up for, we're going to talk about the landscape very briefly because we know that you know what's going on in mental health in kids. We're going to talk about schools and why they're an ideal place for a lot of different interventions. We're going to give you some examples from my program at the hospital and also through Charmain's work at Boston Arts Academy and in the organization that she's founded called InnoCyc. So we're going to give you some ideas for different ways of thinking about kids and youth. And then we hope to close out with some action steps, some ways that we can think about this together and ways that we can think about doing better for kids and families. So that's our plan. We only have 30 minutes and then we have 10 minutes for questions. So we realize that we might talk fast. We're not going to use slides, but we have a lot of talking points. We're going to go back and forth, but we will share our contact information if you have questions or if you want more resources as well. And we'll try to share our web links as we go or through in the question and answer period so that you have those resources as well. So I'll jump in onto the landscape and Charmain, I'll let you add anything you'd like. Like I said, we think you're all very familiar with what's going on out there, but the pandemic has given us a new window into talking about behavioral health. But one thing we do know about that is, everyone is talking about it, which for us, all of us who are doing this work, it's really an exciting time for opportunities. But we have to acknowledge that our behavioral health system was broken and fragmented before the pandemic. And so now the problems are exacerbated, and we're very aware of that. And we know that the system isn't really child, adolescent, family, or provider friendly. And so what are things that we can talk about and things and ways we can think about this differently? So 1 in 5 youth, that's the statistic we hear all the time in any given year, but it's 1 in 5 for adults. So I always want to bring that into the room, especially as there's 116 of us here today. Many of us are struggling as well. But we know that only 25% of youth nationwide are receiving the care that they need. We often know too that it's 8 to 10 years from when a kid or adolescent has symptoms to where they actually get treatment. And so that's like a 4th grader that we identify who doesn't know how to read yet. We might not intervene until they're a senior in high school, which is pretty unacceptable when we think about literacy supports and why are we doing this a little bit differently with mental health as well. So we know that we have to also acknowledge, this is a time of sort of social unrest, racial injustices are happening, police brutality, and this is profoundly impacting people's behavioral health as well, especially Black, Indigenous, and people of color. We know this pandemic has also influenced communities in different ways. So we want to acknowledge that there's grief, loss, identity, and safety that has been impacted for many youth here in Boston, and also I'm guessing around the nation and where all of you are too. So we want to just acknowledge those deep layers. And we know that kids are coming into schools now too. And so what are they bringing in their backpack beyond their pencils and their books? So the need's great. And we know providers, there's not enough of them. There's also wait lists for services. There's a boarding crisis. So all of this, so there's not enough clinicians of color, especially for diverse families. And so this is a crisis. We know we're in it. So are there ways that we can think of different strategies? I think the last thing I'll say, and then Charmain, you can add to this, but up here, the system sort of assumes that an individual therapy model is the way to go. When a kid is struggling, they should have counseling, they should have therapy. And so we actually think that that should be one response of maybe 20, right? And right now we want to blow that system up. Sort of the medical model is not going to reach the needs or even touch the surface of what kids and families need right now. So we'll talk about some strategies and some ways that we've tried to address that over the years as well. But Charmain, what would you add to the landscape?
I think what you raise is so important in terms of just the stats, right? And I think part of it is when we look at those stats and we think about youth of color and students of color, we know that their numbers are also more dramatic. Part of the reason why I'm doing the work that I'm doing. We know that many schools, regardless of where they're located, whether they're in a rural area or an urban area, that the majority of the educators are often from backgrounds that don't reflect the students that they're serving, particularly in urban areas or low under-resourced areas. And it's so important then when we think about youth mental health, we also see the disparities in who gets diverted to mental health services and which students get diverted to juvenile resources or services, right? So we also see that those disparities, and those do have an impact on the mental health and well-being of our students and their outcomes. So I also want to name some of the social contexts in which we're operating in and how that also leads to more harmful trajectories and outcomes for youth of color.
Thank you. So why schools? We think schools are in a really unique position to address behavioral health, social emotional needs. In fact, we might say they're in the best position because kids are there every day. I love these integrated care models coming out of health centers and doctors' offices, but we're also finding that many kids aren't there often, or they're there only when they're sick. And I think with COVID, families have been not going as much. So we're seeing kids who are in need of services and not getting what they may need. We'll share some examples today of our own programs, but we also want to think outside the box a little bit here from this medical model, like we started to say, and think about sort of tiered interventions and sort of public health models as well. And reimagining behavioral health care. I mean, I think all of you are at this conference as a summit to think about this. I mean, we've needed this work for a long time. I think we're being it's more clear that we need different pathways for kids. I think the other thing about schools is, how important it is to ask for youth voice and what they want. What kind of services are they looking for? And for families, I think we're not always asking enough. And so centering that as the key of any intervention is essential as well. The only other thing I'm going to say about schools is up here in Boston, we do have a shortage of positions. And so I'm not sure what it's like in Virginia or for some of you are in different parts of the country, but I'm guessing it's similar. And in Massachusetts, it's district by district, school by school, depending on if we have social workers, if we have psychologists, if we have school nurses, if we have part-time positions, if we have full-time positions. And so previously, Boston Public Schools had 14 social workers. And this year, they've now put a full-time social worker in every building and a full-time family liaison in a building after years and years of advocacy. And people are like, oh, it's solved. But all of us in this work know that that's just the beginning. Like we now will have foundations. But we often are operating with under-resourced schools. So we're very aware of that. So we sort of make that disclaimer about the examples we're going to share and maybe why we do that work to give that context as well. Charmain, before I talk about my program, is there things you would like to say?
Yeah, I definitely want to add to that too. Again, I really, as someone who's worked in schools for 17 years, it was actually my dream job. That's what I wanted to do as a kid, because I wanted to be an adult where students and youth could have a trusting adult that they can talk to. So again, speaking from my students, I hear it time and time again, once you build that connection with a student, they are so connected to you in the school. And they often don't want to go outside to see another therapist, right? Because it's very convenient. It's who they have trust and relationship with. The other thing is for some schools, and for the school, we'll talk a little bit about that. The unique thing about it was that the students they were in an extended learning program. So their day was longer than maybe the traditional day where students got out at 2:30. So by the time our students finished their day and traveled back to their communities, community centers would be closed or private practices would be closed. So there was not, the access to services was very limited. But I think if I were to channel the student voice, it's like they trust their adults in their building, and that's who they wanted to connect with. So I think it's so important to have the services in schools. And I know we're going to talk about how to make that happen, but I think for the youth, if we center the people who need it, right? We think about the voices and the experiences of people who need the services, and we center their voices, we ask what do they need? We'll hear that time and time again, they want it at schools.
Great, thanks. So the program that I work for is called Boston Children's Hospital Neighborhood Partnerships Program. It's a mouthful. We just call it BCHNP. This is our 20th year as a hospital program partnering with the district, which is amazing. I myself have worked in 5 different schools in the city of Boston and then became the director in 2009. This team has 16 social workers, psychologists, and a research and evaluation team. And we partner with anywhere from 11 to 15 schools every school year. As well. So just to share a little bit, people always ask me, the question I get is, how is this funded? And so since this is a hospital association training, I'm going to share that our hospital, Boston Children's Hospital, has a community health initiative that funds this work. And it funds about 1/6 of my budget, which is amazing because it gives us foundational funding to be creative and innovative. And it's also about being a good neighbor, right? How do we, as a hospital and institution, how do we support our communities? I also get support from the Boston Public Schools, and they pay for about 1/6 of my budget in partnership. And then we do a lot of fundraising, so through family and individual foundations, as well as corporations around the city here in Boston, which have really supported our work with refugee and immigrant youth in ways that is just remarkable, like Liberty Mutual, for example. So just want to say that, we do also have an endowment that we started so that we can sustain this work, because a lot of the work we're doing is not billable. So I just wanted to put that out there as the disclaimer. So that said, we don't bill for our services. We aren't diagnosing kids right away. We're in schools, we partner with schools, and we do what it takes. But we're doing it in the scope of social, emotional, behavioral health, and we're doing it across tiers. So we don't want to be doing therapy. We want to be doing group work, classroom interventions, consulting with teachers, supporting the administrators, and thinking about the whole community, not just the kids, but also thinking about the teachers and their well-being as well. So those are some of the things we're doing. As well. And I think our main goal is to increase access to culturally responsive, high quality services outside of the walls of Children's Hospital. It does allow us to do sort of, all sorts of things, from crisis intervention to therapy to family therapy. During the pandemic, we were delivering groceries. Like, I think we don't just think inside of our role, we also think about being an important team member in the school and a part of the community. So we always are focused on prevention, and that's easier said than done because there's always crisis situations. So last year alone, we handled 100 crisis situations. And since we're a part of the building, we can respond within 5 minutes. And that is important because we can avoid kids from coming to our emergency department. And I think that we have really done an incredible job of sort of helping schools understand when it's appropriate to go to emergency rooms and when it's not. And so really being that level of support as well. But in addition to that, we worked with 1,200 students across 60 modules of classroom interventions, which we find to be really important, and hiring people who want to wear different hats throughout the day, providing therapy, but also being a consultant and a trainer for schools and building capacity. So that's our clinical program, but we also have a program, and I'll talk quick because I want to get to Charmain. It's called the Training and Access Project, and it's really about training and consultation for schools. And we designed this 6 years ago. We work with 25 schools now in Boston. We do 11 sessions of professional development, and we supply consultation. And we did this because educators were saying to us, like, I don't have any training in this. It's something that I'm dealing with every day. And I'm not sure when to refer. I'm not sure when to reach out to families. I'm not sure what to say. And so we noticed here in Boston that teachers were leaving the field of education, and that was very concerning to us. So we said, we have to do something to sort of build their confidence and capacity. So we have that. But what we did with that is we put these modules, and I put it in the chat, we took our trainings and put them online, and we did sort of a high quality production so that we could share them with educators across the nation for free. And so we have 6 courses up there. There's 3 on trauma. There's things on understanding mental health in schools, and really just open sourcing this information so that we could really help educators, not just here in Boston, but around. We also just did a documentary for parents on anxiety that I put in there as well, just trying to normalize and reduce stigma as part of our goals. We just want to make these topics more easy to talk about, and maybe even more in depth than just sort of the buzz that's going around now about behavioral health. So the last thing I do in our program is we do a lot of advocacy here in Massachusetts. And there's a children's mental health campaign. And right now we're writing a policy brief on school mental health because there's different definitions, even of those among the field. So how do we sort of think about not just what it is, but what are the roles, the responsibilities? How do we talk about ratios? How do we make sure there's foundational supports for families, no matter what district you live in, no matter what zip code you are a part of? So that has been really wonderful, but there are great disparities here in Massachusetts. So I'm guessing that is happening around. And so how do we, no matter if a family moves from a district to a district, that kids and families know what to expect, and that we can provide some sort of foundational, experiences for families to help bridge the gap. So I'm going to turn it over to Charmain to talk about some examples.
I keep forgetting to unmute. So I just love hearing, so one of the things, I don't know if I shared, so I worked in the Children's Hospital Neighborhood Partnership Program. That was one of my first introductions to school-based work. So a lot of the work that I've done at Boston Arts Academy has really been informed by that partnership between Children's Hospital and Boston Public Schools. So again, as we're thinking about the tiered interventions that we did or we do at the school, I'm no longer there, but still feel very connected to that work. We really, when I started, I'll be honest, when I started, it was literally like, it felt like I was working in a hospital emergency room. We were just in a reactive mode. We were just responding to whatever student was coming in. We were really just responding to the needs. And it really took some time for us to think about, okay, we need to do something differently, right? So while students want one-on-one support, and a lot of the work was crisis response, we also needed to start to build in this prevention work. And it really took our team pausing it and working with Shella and bringing in some other partnerships that allowed us to give us literally the breathing space to start to think about what would prevention work look like in our schools. So some of the work that we started to be able to do, we used a documentary that was done by Children's Hospital, Breaking Free from Depression. So we reconfigured our health education course that had been taught by people outside of the school. And we really wanted to bring that back inside so we had more control over the curriculum. and that we could direct, really respond to what we were seeing from our students. We could really target their needs. So we partnered with Boston Public Health Commission. And so we would do a collaboration. They would provide comprehensive sexual health education. And then we would do a component on understanding depression and anxiety and teaching mindfulness skills. So we started to work with our 10th graders. And then after a few years, we backed it up to working with our 9th graders. So doing those school-based interventions were really important. Another thing that we did and we continue to do is the school had a model of having an orientation for all of the new students. It's an art school. We really wanted students to understand the difference, from a traditional school. We wanted to spend some time with them the first couple of days before school started. So during that time, we'd also administer a global screening survey. Was something that was kind of built organically, and over time we remodeled, redesigned it, and really wanted to be able to collect data and look at data over time. So, but that screening allowed us to understand what were some of the struggles that students were coming in with. Had they experienced bullying? Are they coming in with past trauma, whether it's sexual trauma, child abuse? Do they have a social worker that they're working with? Are they involved with the Department of Social Services? Have they had any deaths in the family? We asked lots of questions. What is their history with depression and anxiety? Have they had any suicide attempts? So we really wanted to get a comprehensive view of what our students were dealing with so we could prepare for them as they entered school. And it has been a valuable program. So we would then read through all their those screenings, and we would then rank students by high risk, medium risk, and low risk. And any student that was high risk, we would do one-on-one meetings with them very early on. We wanted to, for them, for two reasons. We wanted one, to be able to get to know them, and also to introduce them to the services that were at school. Inevitably, many of those students would end up having crises later in the year, or would come back to us because they had made a connection. We would do more group interventions for the medium-sized groups, and then all of our clinicians would actually go into all our 9th grade seminar class. It was like a literacy class. And that's often where we saw a lot of where children struggle with reading or other difficulties. Some of their behavioral challenges would emerge. So partnering with our teachers and doing a push-in model where we would go into students, get to know them, do some modules around social emotional learning with those teachers, end up being really helpful. Again, for us to get to know the students, to help support the teachers, and also to teach skills. We also would do work with our new teachers. Myself particularly would go into any new teacher training, and we would do a module or two on how do you recognize social emotional concerns in the classroom? What do you do if a student says blah, blah, blah? What do you notice if you're seeing changes in a student's behavior? Also, what to do if a student says that they're suicidal? You're not taking it on. So we also had to teach teachers when to make referrals to us versus trying to solve problems that was really out of their capacity. I think we have students or teachers who are very invested, very connected, and sometimes would operate out of their comfort zone. So again, a lot of it was around education with teachers, because they're the first line, view of students and concerns that might be happening. So we really wanted to connect with them. Over time, we would go into different departments because we also wanted to make sure that, I think sometimes the counselors at school are often competing with teachers and curriculum time. And so building good relationships with teachers was also really helpful, so that they could trust the work that we were doing, and that if a student was leaving their class and missing lesson time, that it was for good reason. So that was also really important for us to communicate, but also to build those relationships with teachers. And again, we were doing, more recently, I started doing some social emotional learning modules with our arts classes. We started doing work with our seniors. So doing that classroom-based interventions were also a great way for us to move from that one-on-one model to more group interventions like Shella mentioned before. I know I'm running short on time. And so the last piece that I wanted to highlight was the importance of developing community school partnerships. Again, the partnership with Children's Hospitals was probably as long as you started. I think it was at least 18, 19 years. So that has been a solid partnership between the school and Children's Hospital for many, many years, and a valuable partnership. As Shella said, you know, that clinician who is in the school 4 days a week, it's subsidized, heavily subsidized, which again, for school, which is in a low income, low resource area, we would not be able to pay full, you know, for that full cost of that clinician. We also developed partnerships with an organization called Rosie's Place, which is a homeless shelter for women. So they would actually come to the school and meet with families. They had lots of resources for families around income, you know, help with need and food. So, you know, again, having partners that are able to come to the school building and meet with families is huge. Again, we want to think about what are the needs of the people. And if we're asking them, they're in a moment of crisis to then have to go to 5 different places. School is a central place for families and for students. And so how do we make sure that we're providing services where the people are? As I mentioned before, we also had a partnership with the Boston Public Health Commission. We worked with a number of community health centers who would also provide additional clinical services. So that was really important for me to get to know who's in the community, who are the organizations that I want to build relationships with and trust. So that was important. So again, we could not do the work that we do in the city and for our students without the number of partnerships that we have. So we value our partners and know that that's really important in us being able to continue the work. 2 other things, and then I'll move on. It was also really important for us to have a culturally diverse team. So I was the team leader, a Black woman. We had another woman who spoke fluent Spanish. We had another clinician who spoke Portuguese. Not native speakers, but they built that linguistic capacity. We also work with universities, so we would have interns every year, both social workers, arts therapists, and we also had psychology graduate students. So again, our goal was to try to build capacity and move from that reactive crisis mode to really being able to have sustainable models that didn't stretch our systems and our clinical support. And then lastly, I'll talk about in terms of the program that I developed called InnoCyc, is really an organization that has come out of my work with communities of color in particular, and really providing access for services and changing the conversation about mental health. So, you know, we talked earlier about, you know, just kind of the state of mental health and who gets access, who has access to services. You know, during COVID, there have been long waiting lists, therapists are full. But prior to that, this has always been an issue for communities of color. Therapists of color make up around 15% of all therapists, so our numbers are small. And then we're also dealing with lots of stigma around mental health and access and treatment. I think COVID, this global pandemic has really shed a light on how disparate those services are and how disparate the access to those services are. And so at InnoCyc, our goal is to make it easier and faster for people of color to find therapists of color. And we're also very actively engaged in changing the conversation about therapy and mental health. So that's where I'll leave that, and I'll turn it back over to you.
Yeah, and I know we were going to answer questions in just a minute, but I did want to say, I know we're talking a lot about tier 1 and sort of universal supports and screening kids. And I know a lot of schools are doing this. And I think some are doing it better than others. Like a lot of them are just doing a curriculum and checking it off the box. And I think we're trying to think more about integration, right? Like really making sure that if you're in a school and you ask a kid, is there a trusted adult in this building that you can go to? Are there providers in this building that you can talk to? Are there counselors? If the kids don't know that answer, I don't think we've done enough. And so I think sometimes we lean into this tier 1 sort of interventions, because if that's not going well, it's usually really hard to then do groups or to even do therapy in schools and to even manage the crisis. So everything is sort of built upon that foundation. And so I know that SEL has been the buzz for many, many years. And I just think that there's various different levels of implementation to think about, and to sort of think about who's really benefiting, but always asking kids, who do you go to? For sure. So that's sort of the key, but I do think that, it's about providing the range. Like, we need it all. But right now, mostly out here anyway, the kids who are sort of suffering the most, that's when they tend to get services. And we really want to back that up. Like, how do we proactively, preventatively sort of help support kids so that it doesn't get to that point? So I feel like those are the conversations we always want to be having, and thinking about truly more group interventions and the education that Charmain just talked about. So I'll stop there. And it looks like we have 2 questions so far that we can ask. And Charmain, one of them actually is about,
and let me, before you go there, I do want to just add and emphasize that, the beauty of the neighborhood partnership program is that there's no insurance billing, right? And we know there's been conversation about how do we get, because a fair amount of our students are on the state health insurance. And so some of the partners we have made is with clinicians who can take who take that insurance, and they kind of handle that on their end. But thinking about funding a program that is sustainable, that does work, and provide different options for funding so that people can do the work. And I love you started saying, like, you're able, because of the funding you get from the hospital, you're able to be creative in the things that you did. And I think that was the same model in my school. My school leader trusted me to get things done and to do the things and be creative in the work. And I think that is an approach that I think is really helpful. And it came from student voice, right? It came from family voice. So if we're able to kind of reshape, again, the medical model, who is the expert, right? You think about liberation health models, liberation psychology, and social work, it is centering the experiences of the people who are closest to the problem. So what do they, and they know what they need to work. So we can have funding that recognizes that and can support that without some of those traditional barriers, like you have to prove, that it's going to work, or these things work. So just know that.
So one thing that you just reminded me of is here in Boston, there are 20 organizations doing fee-for-service work in the Boston Public Schools. So I don't know if there's a model like that in Virginia, where, community health centers and other agencies do have their clinicians coming into schools. But there is a lot of conversation about, we're sort of in the same fields of mental health, but school mental health and hospital mental health or community, it's a little bit different. And so we're often training community providers a little bit about schools and sort of navigating schools, getting the referrals, following up with families. It is a little bit different. And there is a lot of teacher dynamics, school leader dynamics, space issues. So we're really lucky in Boston. I know we're over-resourced here in this city. We have a great healthcare system. It still isn't enough. It's still, we haven't solved it. And often people feel like this tier 3, the therapy work, is just a Band-Aid because that's the only solution we have at this time. So thinking about other options as well. And so we are seeing that come to light. The question in the chat was about sort of thinking more about this 2 or second or third tier interventions. And Charmain, I was wondering if you wouldn't mind talking about the BRIGHT program a little bit, because I feel like that's such a great example of what else can be done in schools, especially at the top of the pyramid.
Sure. And I'll just say that while Boston is in general feels over-resourced, I would say that's for some communities, right? So I just want to put that caveat. It's not the same. It's not equitable across all racial and cultural groups. So another program that I didn't mention before is a program called Building Resilience for Youth in Transition. And it is a program that was specifically geared for students who had significant mental health crises and had to leave school for an out-of-school placement, usually a psychiatric hospitalization. And sometimes it's for medical, like a concussion. So the idea was to be able to provide almost like a sheltered support as the students return to school that slowed down the school day for them, built in some clinical support, some academic supports until they felt ready, both from primarily, I would say, from a social emotional perspective, but also from an academics perspective. The clinicians and the educator in that space would also advocate for certain assignments to be excused, or to be able to show competency for certain skills. So it's so funny because that is what we used to do in the school, right? But it was at a very kind of fractured way. We really try to support students because we were a school, we had a high number of hospital admissions. I can go into that. There's a whole different stuff and go down that road. So that really having that structure and support and technical assistance really allowed us to really support those high need students in a very different way. I would say some of the other tier 2 interventions that we did, I talked about, the orientation that we do, that was a very tiered, right? We only focus on our new students. We also did a lot of work, again, our health education classes really focused on our 9th and 10th graders. Those were the students we saw having the most referrals to our office. Those are the students who had the most student concerns from our providers. So we really wanted to target that group. We also wanted to provide supports for our seniors. Many of our seniors are from families who they're the first generation to go to college. They have very few resources in understanding the college process. So we really want to provide supports for them that help them navigate that college admission process from a social emotional perspective, right? How do you work with your family who's not giving their taxes? Or maybe you found out that you're undocumented for the first time in your life as you're applying to colleges. So there are lots of things we wanted to target certain grades because of patterns that we saw over time. So those are some of the other supports that we would provide that were more group-based or targeted by grade.
Thank you. So there's another question about like outside of Boston, which is so important, right? Like Boston is just this little pocket up here that we're in, but the University of Maryland has an incredible school mental health program. So just wanted to make sure that that's closer to all of you. I feel like they've also figured out how to do better funding between like the state and sort of university as well. So thinking about that. But I think what's humbling for those of us who've been doing school mental health for our careers is that it's so different school by school and district by district, no matter where we go. And it feels like innovative or resourceful principals often are leading the way. And people are often recreating the wheel. So I think just, but one message and I think takeaway, I know we're almost out of time, is, to really think creatively about partnerships. And I think bridging that gap and sort of creating a community of care for families and kids that isn't just a partnership with Boston Children's Hospital, for example, but with the community health center around the corner, with the fee-for-service clinicians from the other agencies, to bringing people into teaming, to having more family engagement. But I really do think this requires creativity and also funding, but I think really people taking the lead and reaching across those bridges to build them, because the stakes are high. I think we do know that our emergency rooms are full. We do know that they are overwhelmed, and often they're coming from schools. And so thinking about how we can do some of that education as well. But I do know there's rural areas and more remote areas that don't have partnerships or agencies as much, but thinking creatively about the positions within those buildings. How are we funding positions for schools? How is that a priority as we think about all this new funding coming into schools after COVID as well, and what is really needed? Those are things, but Charmain, what else would you say about as we close out?
Yeah, again, I don't want to sound like a broken record, but I think those partnerships are really important. And again, for me, it was really important for me to make time to get out of the office, particularly during the summer, and see what community resources there were that I was not aware of. I would sometimes ask students and families what were some resources that they were using, because we tend to always go to the things we know. But again, there are lots of resources within communities that are valuable and that the students and families utilize. So how do we elevate that work and make those connections as well? I mean, again, I think the funding is always, I guess, a question. But I don't think you should start there. You should start how can we resolve these issues? What are some things that are really needed? And think about the funding afterwards. I think when we put money first, we kind of limit our brainstorming. So start with a problem, how you can resolve it, and then try to find the funding afterwards.
So true. And I also think, it shouldn't be that certain, like we're finding in Boston, some schools have school-based health centers, some don't. Like we have to figure out ways to have some of these services be more universal, that it isn't dependent on a school or a district. So we're honored to be here. Thank you for your time. We put our information in the chat, some websites and our emails. So if any other questions you'd like to reach out, please do so. And
yes, I want to thank both of you for your time and your expertise. I think you've highlighted a lot of concerns that are across our nation and some wonderful strategies for integrating with care providers to provide the most care and some culturally responsive care, which I think is critical. So thank you both for your expertise today. Thank you to our participants and audience members today for attending. We are now going to break for lunch, and we'll be back at 12:55 for our 1 o'clock session. Thanks so much.
Hey, everybody. Have a great day. Enjoy the rest of this conference.